Okay.
She come and stay with me. Let's attend together.
What's that?
Need to see myself. Hello, can you hear me, Bishop?
100%.
Okay. So what time are we starting?
Once I press the record button in, I need to get my script ready.
Don't record yet, so let's still be gisting. This network is, you can vouch for it. Yes. Hey, my battery is 45% too. What's yours?
Mine is there's 4 of them.
Okay.
But there's no way you would charge.
Okay.
Okay.
You said I shouldn't press I shouldn't press record yet.
Okay. Hold on, please. Hold on.
Are you
Don't
ready?
record yet. Don't record yet. No, a few minutes, please. Yes, but it's not balanced.
But do you need, you may need water. You may need water to keep your throat wet. Because it's gonna be a lot of talking.
I first say inaugural. Okay.
Are you ready?
I don't trust this thing, right? You don't trust it, so. That's so.
Well, once you're ready, you let me know.
I think I've hacked it. Okay, let us do a rehearsal.
Okay. Well, so
just like 5 minutes.
Yeah. So we're going to be talking about kidney disease. Kidney is one of those organs that you might not even know you have until sometimes the only time people know they have kidneys when they run into problem. So, and like any other thing that we own, house, car, it needs to be taken care of. So also the kidney, and kidney, you know how important kidney is. So,
yeah.
No, but let's talk about. Let's talk about even your passion. How did you choose renal medicine out of all aspects of medicine? I said, how did you choose renal medicine?
Okay.
Yeah, I'm listening.
Okay, so well, researching through medical school, renal medicine was not my priority, but by the time
I think the
what
network.
happened? Is it from my
Yeah,
my network?
Yeah, it's possible. It's possible that your network, mine
Not.
is having. No, but I think I can hear you now.
Hope you will not disappoint again. Oh, Nigerian network. Oh.
No, don't worry. Don't worry. Even here, sometimes I interview people here, and there is concerns with network. But are you ready
Okay.
now?
The live or just the test run as well? The test run.
No, the
So why
live,
nephrology? Huh?
the live.
The live.
Yeah, yeah, yeah. No, but it's not going to be different from the normal gist that we have. The unique thing about what we do is the simplicity of the discussion. We try to
Okay.
make it as demedicalize it as much as possible so that anybody watching will be able to pick those vital little information that might be helpful to them.
Okay. So it doesn't sound like a Viber.
Yeah, it doesn't sound like Viber. So, so let me, should I press record?
Wait though, let me finish brushing my hair. Oh,
Yeah,
okay. I think I'm good to go.
okay. So, good evening to our viewers across the globe. Once again, my name is Dr. Oyekon Olufemi. Your host of the program Health and the People. And in the course of last month, we were discussing mental health and wellness, and we brought quite a few medical experts. We brought the psychologists, we brought psychiatrists, we brought general practitioners to discuss the importance of mental health. And then we promised that in the course of next month, which is this month, October, we're going to be diving a bit deeper into medicine that we pay particular attention to Africa. We titled today this month's discussion Focus on Africa. And one of the topics we're going to be talking about is kidney disease and access to dialysis. And in doing that, we're going to be looking through several aspects of this very silent but important aspects of our daily living. And joining me to discuss this topic is a familiar face on our platform, a consultant kidney physician, Dr. Aramide Akinloye. You're welcome to our program. Yeah,
Good evening, Dr. Femi.
yeah, you're welcome.
Good evening, Dr. Femi. Thanks for having me around.
Yeah, so
It's good to be happy.
yeah, for some of for some of the people who have been following us, Dr. Aramide is a familiar face. But to those who are just going to be meeting you today for the first time, can you just do us a bit of favor to introduce yourself and the part of medicine you have expertise in?
Okay, thank you very much. My name is Dr. Aramide Akinloye. I'm a consultant nephrologist. I
Mhm.
presently practice with Reddington Multi-Specialist Hospital, as well as the Nigerian Navy Medical Services, with special interest in kidney diseases.
Yeah.
So that's it.
Yeah, so I think we couldn't have asked for a better person to talk about kidney disease. So let's go into a little bit of a preamble that what we do is talk about the fact that kidney is one of those very vital organs that helps with our daily function. One of the key importance of kidney is to remove waste from our body. And if the kidneys are not functioning at their best, there's a very significant risk that you may be exposed to things like infection, things like cardiovascular disease, including stroke, and other complications that we might not be able to mention, depending because of the extent of the medical information that's required or with kidney. So if you've spent a very significant part of your medical education studying kidney, that means it must be something very important. So let's talk about few things that people may be interested to know. People may want to know in terms of what are the common causes of kidney problem.
Okay, thank you very much. So, like you rightly said, the kidneys are the filtration organ of the body. That is what the kidneys do, is that they filter the blood, and then bring out the waste products, and makes the blood a cleaner environment, basically. So the toxins from the body is washed out through the kidneys, and the kidneys usually primarily are located behind, backward, not in the abdomen like most people think, not anteriorly. So the
Yeah,
kidneys
yeah.
are more of posteriorly pipes that run an anterior course. So the commonest cause of kidney disease worldwide is uncontrolled diabetes mellitus, and in the Western world. However, in African and in the Black, in Africa generally, it's more of hypertension. So when we consider this together, poorly controlled hypertension over time, poorly controlled diabetes mellitus over time, and then sometimes a lot of other rarer causes like obstructive causes. For example, in men with prostate disease, in women with fibroid, there are also the rare causes such as infections. So people that have HIV, for example, or even hepatitis can come down with kidney diseases. Then the other rare causes are um, things that can, like kidney stones, can also cause kidney diseases. So all these put together are common causes of kidney diseases. But by and large, hypertension and diabetes remains the two most common causes of kidney diseases worldwide.
Yeah, thank you. Sometimes, like, I'll need to appreciate the simplicity with which you help us to understand what are the most common causes of kidney problem. But in terms of the symptoms, that what you will see that will make you feel that, oh, my kidney is beginning to misfire, or my kidney is not working at its optimal level. Well, what are the subtle but common signs that people should be looking out for when it comes to kidney concerns?
Okay, we must first of all take note that sometimes kidney diseases are actually asymptomatic. That is, in the early stages, they show no symptoms at all. But usually, as it progresses, you may begin to have clear-cut symptoms like facial puffiness, especially when the person wakes up from sleep in the early morning. There's a facial puffiness, and then there's also leg swelling, body swelling generally. There's also the tendency to have easy to get tired easily, and that's because with kidney disease there may be what we call anemia, which is shortage of blood, because there's a chemical usually that's meant to trigger production of blood, but with kidney disease this chemical is not produced, so the person may become anemic, so the person becomes easily tired as the blood level is not optimal. Also, the person may begin to notice that there is reduced urination. The person just knows that I don't urinate as I usually do urinate before. Usually I urinate 4 or 5 times. Now I urinate once or twice. I don't even urinate at all. So that's another symptom. And then in the florid, worse, severe cases, the person may become uremic. That is, the toxins in the body may become so high that the person may become breathless. The
Mm.
person may become irrational, confusion. But when we are getting to these florid symptoms, then it is already advanced. But
Mm.
by and large, it is usually asymptomatic in the early stages. So it
Mm.
usually cuts as during routine screening. Yeah,
Mm.
in
Mm.
the early
Mm.
stages, it can be asymptomatic. So the mere
Mm.
fact that you walk around without symptoms does not rule out a kidney disease.
Yeah, yeah. Thank you for bringing that up. That even though some people may be walking normally, and sometimes at the background their kidneys may already be may have already started showing signs of deterioration. But in terms of your clinic, I know you offer expert service when it comes to kidney problem. You offer expert service when it comes to kidney problem. Is it what kind of patient do you see? Are they the affluent ones, or is it easy to are the poor people able to get access to you? Or just give us a background of the demography of the kind of patient that have access to you, both as when you were in the specialist training in Lagos University Teaching Hospital, and now working in one of those very I'll say, how do you describe Regency Hospital? Those wealthy set of people's hospital. So let's talk about your patient demography.
Okay, so like you rightly said, practicing in the tertiary institutions, like teaching hospitals generally, we tend to see all cadres of social economic status. We see the low income earners, the medium income earners, and then of course the high income earners. So you see all three cadre of people in tertiary institutions. However, in the private sector, usually you see more of the middle and mostly the high income earners. And this is for obvious reasons, because the cost of care in private sector is usually much more than what we have in the tertiary institutions. Yes.
Yeah. No,
So
but
that's it. So in
yeah.
the tertiary institution, sorry.
No, go ahead. I'm listening.
So in the tertiary institutions, for example, you can see the regular artisans, regular everyday market women, all artisans around. You can see them in the tertiary centers. But usually when you come to high-end private centers, they may not be able to afford the cost of consultations, investigations, and treatment. So usually it's the high-income earners that we tend to see there. Yeah.
Yeah, you mentioned one very important factor in terms of access to expert service, and you mentioned income, and that can play a significant role in terms of the costs of having to see a specialist. I'm just talking about price wise. What's the price to see a specialist in terms of, but knowing the price, we're also going to talk about are there support groups that can help people who wants access to credible service to like get some funding. Let's go with the price first.
So when you talk about okay, good. So when you talk about price, are you talking about the government sector, tertiary institutions, government-owned institutions, or the private sector? Because I mean the prices differ.
I want us to look at every aspect, both the government sector, the private sectors, and even the funded. Is that the HMO or what do you call it? That HMOs driven ones.
Okay. So for example, let me start with the private sector, for example. So usually consultation, so um, having access to a nephrologist, there are different sections to it. So we have the consultation. This is when the patient sees the consultant on a one-on-one basis, the review results, complaints, the consultant examines, and then a decision is made. The consultant tells the diagnosis and what not to do. So that's what we call the consultation. So based on this consultation, the managing consultant then requests for some specific investigations, which are called tests. And these tests could be blood, could be urine, could be imaging like ultrasound scan. So the cost of consultation is completely different from the cost of investigations. And then based on the test or the investigations, like we have said, the result will then determine which treatments to give, the treatment options, that is the medical and the medications, and then if the dialysis is meant to be commenced or not. So if you look at it, we have the consultation part, the test or investigation part, then the treatment part. So the treatment now could be medical, that is medicine, or renal replacement therapy, that is dialysis, if need be. So let's talk about consultation. So it differs actually from hospital to hospital. But on the average, in the private sector, especially here in Lagos, it ranges between a 50 and a 100K for consultation in the private sector. So
Yeah.
usually we have the first time consultation and then the follow-ups in the private sector. Take note.
Okay.
So for the
Okay.
investigations,
Yeah, go ahead. I'm listening. I'm listening.
so for the investigations or the tests, like I said, we have the blood test, we have the urine test, and of course we have the imaging. And usually, once we're doing imaging, we start with the basic ultrasound scan. But in total, when you couple all this together, that is the blood, the urine, and the scan, on an average in the private sector, you may be spending between 200 to 50 for the basic test. So
Mm-hmm.
this now depends on what you find. So for example, if I find something suspicious, I can then request for example, if I've requested for a basic ultrasound scan, if I see that, oh, I'm not too sure of what is going on here, I need a higher scan, I can then request for a CT scan. And of course, the price of a CT scan is not the same as an ultrasound scan. So
Absolutely.
then, like that.
Yeah. Yeah.
Yes. But when we come to the government-owned institutions, things are a bit. When we come to the government-owned institutions, things are a bit cheaper. Although it's been a while I left the government practice, but the last I knew, I think consultation in government practice should still be less than 10,000. I stand to be corrected though. I think consultation is still less than 10,000 in the tertiary institution, and of course the investigations as well um, is not as much as what I have quoted for the private sector.
Okay. Because
And then when it
when
now comes to treatments, medications, and
yeah, go ahead, Dr. Ramide. Go ahead. I'm listening.
okay, so when it comes to treatment, okay, when it comes to treatment options, medications, and if dialysis is required, for example. So in the private sector, I think dialysis goes for an average of about 60 to 80,000 naira per session. While in the government session, luckily, from the review we had from the president of the federal government, he had just recently subsidized dialysis in government-owned tertiary institutions to 12,000. So you can see the disparity between 12,000 in federal government-owned institution and 70 to 80 in the private-owned institution. And for patients on dialysis, for example, they may need to do 2 or 3 sessions per week on a weekly basis to be able to live a fairly normal life. So there's actually the price difference. But of course, the comfort also comes in. I mean, patients are generally more comfortable in private sector than public sector. And then, of course, the brain drain now is not even really helping matters in the public sector.
Yeah, yeah. I wanted to come back to that, but thank you for bringing that up in terms of the brain drain, in terms of the cost. But when you look at the cost of access to dialysis, access to expert service, and then you look at the campaign that we are doing for people to be aware of what's happening in to their kidneys and what to do differently in terms of ensuring that they are taking the right decisions to keep their kidneys safe. Do you think that in terms of both the government and the public sector, are there enough awareness in terms of making people understand the importance of the kidneys?
Well, I think the awareness, to be honest, I think the awareness is getting better um on on a daily basis, yeah. Because now we have a lot of campaigns, we have a lot of newspaper adverts, radio jingles, we have a lot of talks. Like you're aware, we have the World Kidney Day that holds every third Thursday in March annually. And during this program, most institutions go all out to do outreach at public places. And even aside from the World Kidney Day, different institutions or people from different places go out to actually go and make awareness for people when available, especially in public places like churches, markets. I mean, so I think the awareness is going on. And also the Nigerian Association of Nephrology is also doing a great job when it comes to that, having a lot of people go out to make awareness and jingles everywhere. Yeah, I think it's getting better compared to what it used to be.
Okay, but in terms of thank you for helping us to understand that there is already a lot of effort in terms of making people understand that the importance of kidneys, and also there are campaigns going on. But in terms of when we look at in terms of the number of expert service that's available compared to the population, do you think that in terms of the availability of the service, do we have enough service to be able to go around to people needing it?
So so let's talk about the manpower, right? That's
Yeah,
the
yeah.
nephrologists the doctors, the nephrology. Yes. So we also you have the, I'm sure you know, we also have the nephrology nurses. These are
Mhm.
nurses that are specifically trained in nephrology units. That is the
Mhm.
kidney department. And they are the ones that are usually in the dialysis centers as well as in technicians. So in all fairness, the manpower is actually reducing. But take note that this is not only a kidney related or a nephrology related thing. It actually cuts across all specialties. And like I said, this is because of the brain drain that gets worse on a daily basis. So the manpower is reducing compared to the population load, not only in nephrology, but across all medical specialties, majorly because of the brain drain.
I think that's very important because recently the former deputy Senate president of Nigeria, Senator Ike Kuremadu, had a case where wanted a transplant for the daughter, but didn't do it in Nigeria. Wanted to do it in the UK, but I think there was some fault in the process. But do you think, in terms of specialist service to deliver such high quality, um, in terms of transplant, did you think that we have both the technicality and the manpower to be able to do something like that safely in Nigeria?
Yes, yes, we do. We have the technicality and manpower. Presently, a couple of, well, there are two major, okay, there are a couple of private facilities, for example, that are into transplants in Nigeria. But one major one, whose name I wouldn't mention, is in Lagos, and another major one in Abuja. And on a monthly basis, they are churning out good numbers of success rates. And most of the surgeons are even local, they're Nigerian surgeons. That's what I meant. And then the private sector also is doing a great job in terms of transplants. So yes, we do have the manpower, but the only issue of transplantation in Nigeria now is one, the issue of donor. We still have issue with donation. Donor is not organ donation in Nigeria. Number one, we don't have laws presently on ground at the national level to standardize our organ donation system. Then two, because of cultural and religious belief, we don't have that high donor turnout as we do in the Western world. Then here in Nigeria also, there's something called the disease donor. So we have the living donor, this disease donor. The living donor, as the name implies, is when a person that is still alive donates his or her kidneys, while the disease donor is using a brain dead or organ dead person that donates his or her kidneys. But presently in Nigeria, we don't use disease donors yet. And even for the living donors, the awareness, or rather um, let me see, the willingness to donate is not really as what we have in the Western world. Yes, so donation
Yeah.
is a problem, and then two, legislation is a problem, and then most importantly, funds are funding. So the funding, donation, and legislation, those are the challenges we have with organ transplantation generally in Nigeria. To be specific, kidney transplantation.
Yeah, I must really appreciate the fact that for making the problem very simplified. You talked about this level of awareness of people in terms of the willingness to donate, and then talk about legislation. And I think that when you look at legislation, it's a very important part because here in the UK, possibly maybe speaking for a few of the Western world, when it comes to organ donation, there is the there are very strict laws that governs who can donate and when to donate, and even the non-living donor that you talked about too is also a very rich pool here because if somebody, most of us, somebody including myself, signed up that in case something happened to us, whatever organ is salvageable can be used to help whoever is alive. But now talking about, you said.
So that's why we don't have in Africa. We'd rather go to heaven with how we came. So Africans don't believe in that presently, probably because of the cultural belief, the religious belief. I don't know, but we have challenges with that.
Now, talking about the fact that you mentioned the cost of um, the dialysis, you mentioned lack of expert service, you mentioned lack of legislation. So, with all of this huge burden that if we had to mm, ensure that the problem revolving around kidney problems and access to service is resolved, I think the bulk now falls back on the individuals in terms of what can be done to prevent their own kidneys from being from decline or declining functions or from not working properly.
Okay, very good. So that takes us back to what I earlier said. So usually with kidney disease, the major thing is you should be able to control the underlying cause. So it's like you have a stubborn tree growing behind your house and the tree is just becoming a nuisance. You don't cut the branches, you uproot it. So when we use the analogy for kidney disease, the root of the problem usually, like I've earlier said, is uncontrolled diabetes, uncontrolled hypertension over a long time. So if you want to reduce the possibility of you having a kidney disease, know your digits. Am I hypertensive? If yes, try to be on regular medications and control it as much as possible. Are you diabetic? If yes, try to have your medications and control it much as possible. Then, most importantly, also a healthy living, like alcohol in moderation, smoking cessation, and weight control. Because there's also the part of the obesity related kidney disease. And then, usually, there's also the part of drugs. Yes, that's another important thing in Africa
Africa.
now, in Nigeria. We are beginning to notice an increasing trend in kidney disease in the young people. When I say young, I mean less than 40, 45. And usually these people are beginning to abuse a lot of illicit drugs. So some of these drugs are actually toxic to the kidneys. So high dose of prescribed drug overdose, like there are some drugs we call NSAIDs, for example, ibuprofen, diclofenac, abuse over the years, over time, can damage the kidneys because they are not kidney friendly. So you shouldn't abuse drugs over time. Rather, go to the hospital if at all you need to take some medications. So drug abuse is actually another cause of kidney disease, though not as common as hypertension and diabetes. Another trend we are beginning to have now is the use of skin lightening chemicals. I call them chemicals because I don't believe they are creams or soaps. Most of these creams or soaps have high mercury, high metallic components that penetrates the pores of the skin. And once it gets into the body, unfortunately, is dumped on the kidneys over time. So the continuous use of these very poisonous chemicals are also dangerous to the kidneys. So by and large, why would I glow when my kidney is dying? So I'd rather have a healthy lifestyle, use normal creams, and make my kidney healthy. So in summary, control your hypertension, control your diabetes, live a healthy lifestyle. Do not use skin lightening creams or skin lightening products. Stay away from excessive alcohol. Do not smoke and do not use illicit drugs. I think those are the basic things that we can do to control our so not to be at risk of kidney disease. And for men that are on the age side, like 60 and above, have your prostate checked because sometimes prostate disease can be a cause of kidney disease because there's actually a relationship between the prostate and the kidneys. It can cause a backflow and then cause obstruction. But once the prostate disease is taken care of, there may be no problem on the kidneys. So if you look at it, a lot of these things are actually avoidable. Although in
Absolutely.
rare cases, some may be genetic and uncontrollable.
Yeah, so I really want to appreciate you for that, for talking about the fact that things like high blood pressure needs to be controlled, things like diabetes. So in Africa, when the doctor said take one tablet of ibuprofen, some people will take four. I say, that doctor does not know how the pain is doing me. It's all that kind of thing that I'm
And then some people turn into multivitamin. They take it every day. You
yeah,
have a
yeah.
patient come to your clinic that I've been taking it for 4 months. What? How can you take ibuprofen daily for 4, 5 months?
Yeah, yeah. No, especially when you see some of these low income earners, people who do menial jobs like maybe bricklaying or maybe some of these, and they think that by
No,
using those
so
things.
sorry to cut you short. Sorry to cut short, Dr. Olufemi. In fact, sometimes we have very learned people that abuse these drugs. So you're right, yeah, the low income earners is common among them. But even some learned people, I have knee pain, I have bone pain, it makes me get better, it makes me sleep better. And they are on it for months, for weeks. So I mean, like you said, sometimes the knowledge or they do not know. I mean, what you don't know, unfortunately, and that's why we go all out to let people know. It's commoner in the low income earners, but we have some very knowledgeable individuals that abuse some of these harmful medications.
Yeah, I'll say thank you. One of the things that I wanted to look at before we move forward is because there's been, while you're talking, there's been a lot of internet glitch. So I wanted to see if I could transcribe what you're saying so that maybe, yeah, I think it possibly may be better that way. But thank you for mentioning things that people may be doing to the damage the kidney without knowing. But sometimes, Dr. Ramide, some people think that when it comes to kidney, the only function kidney does is to get urine out of the body. Are there any other thing that people should know about this kidney that this kidney does to our body apart from helping to convey urine out of the body? Any other function?
Okay. So, like you rightly said, the one of the major function is to take urine out of the body. And of course, in taking urine out of the body, most of the toxins in the body are being taken out.
Mm-hmm.
Two, there's also what we call electrolytes. So these electrolytes are like salts, let me put it that way, salts of the body. So the kidneys help to regulate these electrolytes within an acceptable range. So these salts, for example, we have sodium, chloride. Don't let me bore you with their names. But in case it's too low or too high, there are different things that could happen. So what the kidney does is that it keeps these salts of the body within the acceptable range so that it doesn't go too low or too high. Another function of the kidney, like I've earlier said, there's a chemical called erythropoietin. So what that chemical does is that it's like a messenger. It's the one that tells the bone to produce blood. So blood is actually produced from the bones, from the long bones of the body. But without that EPO, the blood will not remember that I am to produce blood. So it will just be there for nothing. So it's that EPO that tells the blood, oh yeah, knock knock, produce blood. And once the blood is there, after 2 to 3 months, about 120 days, the blood dies a natural death, and another one is formed on a 3 monthly basis. So people that have kidney disease, unfortunately, lose the production of this special chemical I've talked about. So because that chemical is no longer there, what do you think will happen? Nothing to remind the bone to produce blood again. And that's why when you see people with kidney disease, they come down with blood level as low as 14, 15, 16% instead of the accepted 35 to 40 and above. So one, two, that's another function of the kidney. It helps in blood production. Then there's also what we call calcium metabolism, which is good for which is what we use for our bones. So the kidney has a way of regulating calcium. When there's a problem with the kidney, there's what we call the bone disease. So the patient will come down with bone pains and different things. So apart from toxins, the kidneys also help in blood production, also helps in regulating the salts of the body, also helps in regulating the bone stability in the body. So that when there's a kidney disease, there may be bone pains and bone disease generally. So these are the extra urinary functions of the kidneys that is not commonly known to the everyday man.
Absolutely, absolutely. So I'll say thank you for bringing out this information. So when people think that as long as you're having urine, you're able to pass urine, that there is no problem with your kidneys. Thank you for letting us know that the kidneys are the ones responsible for blood production. Is also responsible for ensuring that whatever chemicals is running in our body, they help to balance it right, and it's
Yes.
also responsible for ensuring that not just water getting out of the body, Even blood pressure, it helps to control blood pressure. So yeah,
Also,
but
exactly.
yeah,
Yes.
yeah.
Yes.
So
Because kidney disease is one of the most common cause of uncontrolled blood pressure. So it can be vice versa. Once there's kidney disease, the blood pressure can go high.
mm, mm,
So
mm,
that's
mm.
what we call renal causes. So renal cause is one of the most common cause of secondary hypertension. Because like hypertension can be not primary or secondary. So when it's primary, we don't really know the cause. It's just probably genetic. But when it's
Mm.
secondary, one of the most common causes of secondary is the kidney disease because there's a complex pathway that helps in regulating the blood pressure in the kidneys. It's called renin pathway, but like I said, I wouldn't bother you, but it's one of the most common causes of secondary hypertension.
No, no, no. I know, I know. Thank you. I know you are very brilliant, and I don't want us to to go to that point, but I know that if we want to make it very academic, I trust your intelligence. You are absolutely very fabulous when it comes to that. But I just wanted to ask. No, I wanted to add something with regards to we've talked about kidney disease, we've talked about how to prevent it, we've talked about what causes the problem. Then once the problem have been caused and the kidney have been significantly damaged, then we now get to the point of dialysis. Well, what do you usually see in a kidney that will make you tell this person that at this point we can no longer rely solely on your kidney to pass waste out of your body? You are going to need dialysis. What do you usually see as a consultant?
Okay, so there are two things we watch out for. Number one, we have what we call the lab parameters, that is the figures. Then we have the clinical parameters, that is the patient as a being, as a human being. So the toxins, once the kidneys has been very, very diseased and is the advanced stage, those toxins look for where to hide. So, for example, it can go to the brain. When it gets to the brain, the patient may begin to act confused, and the patient can even have frank seizure. So seizure confusion in a patient with kidney disease is an indication for urgent dialysis. The body has retained too much toxins and is now in the brain. Two, it can go to the lungs. When it goes to the lungs, it accumulates fluid. Normally, there should be no water in the lungs, but when the water gets to the lung, the patient becomes extremely breathless. The patient cannot breathe. By the time we listen to the patient's chest with our stethoscope, it is flooded. So the patient is practically drowning in his own lungs. Like water is in his lungs everywhere. Cannot speak, cannot do anything. The patient is actually gasping for breath. You need to dialyze that patient as soon as possible. And that's what we call pulmonary edema. Edema can be outside in the limbs, but when it is in lung, that's what we call pulmonary edema. And it's very, very life-threatening. If that fluid is not immediately removed, the patient will drown in his own fluid almost within a few moments. Then these toxins can also go to the stomach. When it gets to the stomach, the patient starts to vomit, starts to have hiccups, and then may even begin to pass bloody stool. So this is another indication for dialysis because if not careful, the patient can bleed out through the GI tract. Then we also have the patient can also be having intractable itching, will itch badly that the patient is just not comfortable. And like I've earlier said, sometimes we have recalcitrant hypertension. The BP just goes AY. The patient is on 4 or 5 classes of BP medications, including diuretics, and the BP is just not going down. These are urgent indications for dialysis. That is, at that point, you cannot wait for the kidney to work on its own. You have to take out the toxin as soon as possible. Also, when you look at the lab parameters, there are some figures you want to look at that no, this has to be dealt with urgently. For example, you have something called the creatinine. That creatinine, if there's no kidney disease, shouldn't be more than 100, 120 thereabouts. But with kidney disease, it begins to rise. In people with severe disease, it gets to the thousands. So once you see a patient with 1,000, 2,000, you don't want to dabble, you don't want to play with that patient. The patient needs to dialyze ASAP. Because if you don't dialyze soon, there are sometimes not even the kidney disease may be the problem. The patient may even have these things in the heart. So the patient may have palpitations, chest pain, and all these things. And so you have to dialyze. So basically, you have the clinical indications and the laboratory indications. But the clinical indications are usually very obvious and need to be done almost immediately. And like I've said, it can affect almost every organ: the brain, the heart, the lungs, the gastrointestinal tract, the skin. So these are indications for dialysis. And when we talk about dialysis, fortunately, there are two. So there can be the acute indications and there can be the chronic one. The acute one is that a patient just has a disease that, after a while, the kidney is able to pick up on it. So that's what we call acute kidney disease. Luckily, after a few sessions, the kidney returns to normal. But for a patient with chronic kidney disease, the patient may become life dependent on dialysis or transplants, as the case may be.
Mm-hmm. Now,
so those are the indications. I don't know.
No. I possibly say that. To be honest with you, I didn't know there was so much indications for dialysis. By listening to you, I'm also learning. I must confess. But I also thank you for that very educative session. But we said something about access to dialysis. Let's even assume. Let's even assume that somebody is wealthy enough to be able to afford dialysis. What's the life expectancy? How long can somebody live on dialysis? Or how, from your own experience, how long has been somebody who have been who has been under dialysis? How long have they been able to be alive? I'm trying to make the question a bit simple for myself. So, but did you understand my question,
Not
please?
political.
You said?
Yes, I do. But I
Yeah,
need
go
to
ahead. Go
refer. I
ahead.
need to be sure.
Yeah. So the question is,
Okay. So to be honest, when we talk about dialysis,
mhm.
um, just to clear some things, there are actually two types of dialysis.
Yeah.
So there's what we call the hemodialysis, and there's what we call the peritoneal dialysis, the PD. But unfortunately, here in Nigeria, peritoneal dialysis is not, we don't have it. Let me put it that way. But in the Western world and maybe some parts of Africa, they have both the peritoneal dialysis and the hemodialysis. So from the word peritoneal just simply means the abdomen, the stomach, later. So that one, the exchange of the dialysis takes place in the abdomen. That's what we call peritoneal dialysis, which is more common, which is commoner in the Western world than this part of the world. So we don't even have it here anyway. So let me cone down to the hemodialysis we readily have. I just said that for knowledge sake, so that people can be aware that when we say dialysis, there are actually two types of dialysis: the peritoneal dialysis and the hemodialysis. But here in Africa and in Nigeria, to be specific, what we do here is hemodialysis. Ideally, once a patient becomes advanced kidney disease patient, that is, the kidneys can no longer live on their own, the dialysis should be at least 3 times a week, thrice weekly, to be able to have a good quality of life. But I've earlier said, most people could not or cannot afford this 3 times weekly dialysis, because dialysis is about, like I said, 78 to 80,000 per session. And by the time you do the multiplication, that's an average, a modest average of about 200,000 a week.
And that's
200
more
times
than
4, that
that's
is
more than
800,000 a month.
yeah, that's more than an average person's minimum wage in the country, which is more like
Yes. Did you
yeah.
say minimum wage?
Yeah,
What's Dr. Femi, the minimum wage here I hope you remember what our minimum wage is.
I think it's 75,000 naira, something like that.
Uh-huh.
Yeah,
Okay, so and now we are talking about 800,000 dialysis monthly.
monthly.
So
Wow. Wow.
by and large, people are not able to dialyze as they should. So they dialyze, let me say, PRN. What PRN means is as necessary. They don't come for
Yeah.
dialysis unless there's a trouble. They
No,
don't come
but
for dialysis unless they are severely ill. They don't come
wow.
for dialysis unless it's an emergency. And truth be told, we wouldn't completely blame them. But that's, I guess that's one of the reasons why the Nephrology Association was able to advocate for a reduction in
In the
dialysis,
cost.
which luckily we've been able to get to, in the cost to 12,000. So by and large, people don't dialyze as often as they should. And luckily for the people that can afford these amounts, some of them would rather go for transplants. So by the time they do the math, why don't I just go for transplant than going in and out 3 times a month? Personally, in my own experience, the highest person I've seen in practice with regular dialysis is about I think 9, 10 years, and the person is actually a colleague in the medical profession. So maybe things are actually cheaper, or maybe some things are way for ease. I don't know, but the person has been able to, that I know as a person, about 9 to 10 years in Nigeria. But my colleagues that practice in the Western world, I've seen, of course, longer figures, more higher figures than that, and that's because of, like, for obvious reasons. The healthcare insurance is there. People dialyze often. In fact, I was told by my friends that if you don't call for dialysis, they will come and look for you in your house. What happened in Nigeria on your own? No.
Yeah, yeah, because here they sometimes send the ambulance to go pick you up and dialyze you, give you the ambulance to take you back home to ensure that yeah,
We don't have
and
that luxury. We don't have that luxury.
yeah, and I think that that that's one of the reasons I thought that your presence to discuss this. We talk about what's available in the other part of the developed world, and also what can be changed locally in terms of access to dialysis in Nigeria. Rightly, you mentioned the fact that there has been some significant subsidy in terms of access to dialysis by the current president, President Bola Ahmed Tinubu. But in terms of, yeah, in terms of access to that service, is this service available to the ordinary people, or is it just for the affluent and the wealthy?
Sorry, I didn't get that question. You mean the subsidized service?
Yes, yes. The subsidized service, is it available to the affluent people, or is it just is it can ordinary people walk into any teaching hospital and still have access to the same service?
So we have to be careful. We have to take note that how many of those. So, for example, let's take Lagos State as an example. How many of those hospitals do we have in Lagos State? Do you think we have in Lagos State? Just two. So we have two federal hospitals that have subsidized dialysis, Luth and Ebute Meta. So, and don't forget, like I've earlier said, these centers are manned by humans that are meant to be specialists. How many do we still have in practice? The number of patients that need dialysis care outweighs the number of centers that presently have subsidized cost. So an affluent person would rather not go through the stress of going to queue. So let me put it, the patient load is more than the what the capacity of each center can take. I don't know
Mm-mm-mm.
if you get what I'm trying to say.
Absolutely, absolutely,
So
absolutely.
is that yes. So it's available, but to be honest, it's overwhelmed. Yes, they're being overwhelmed because there are
Mm-mm.
just two centers in Lagos State, for example, and of course, Lagos State has one of the highest burden of kidney diseases in Nigeria for obvious reasons. It's the most populated state in Nigeria, so it stands to reason that we should have one of the highest burden of kidney disease. But with just two centers, and how many people manning those centers?
Yeah,
So
yeah. So
usually, looking at the pool, right, most of the people that go are actually the low income earners because, in all honesty, a high income earner would think that why would I be struggling with this other person when I can always pay? And then some HMOs also assist depending on the package you do with them. If it's a co-pay, if it's a 20% pay, 30 or 40%, depending on the package, basically. So it's open to everyone, but the number is
overwhelming, overwhelming. Yeah, yeah.
yes,
I
it's
think that
overwhelming.
that
Yes.
that's yeah that's where we want you like in terms of I think we're gonna, yeah, thank you. So what I'm going to be talking about in terms of our message is out here. We have very supported groups of Africans in diaspora. In terms of if people from diaspora wants to support to make sure that the service is not just available but is accessible by the ordinary people. What's your message to people that want to support these ordinary people? Do you have any message for them?
Yes, so yes, we actually look forward to collaborating with people that want to support maybe Nigerians in diaspora that want to support. Yes, it's we're open to collaboration, especially for the low income earners, especially in the tertiary institutions. So usually they can collaborate with they can work with the Nephrology Association of Nigeria. I mean, that's our umbrella body where everybody in Nigeria comes to get all nephrologists in Nigeria. That's the umbrella body we have in common. So by the time they meet with the executive of this body, I think they will be in a better position to know how to streamline or how to look at the centers that would most benefit from whatever help or aid they want to give. And of course, by the time they reach out to teaching hospitals and the hospitals that do transplants, if transplant care can also be subsidized or maybe helped out, yes. But like I said, reaching out to the umbrella national association, it's one way, one go forward.
Absolutely,
And then
absolutely.
luckily, we also have the transplant system in Nigeria. Yes, so we have two umbrella bodies that covers us as an association: the Nephrology Association, Nigerian Nephrology Association, and the Transplants Association of Nigeria. So the Transplant Association is just not kidney, liver, corneal transplant, organs transplant generally, but they can work in tandem with these two organizations I've talked about. We then now have our state chapters, and then they will be able to advocate for which and then streamline who will best benefit from what.
Yeah, so
And I think
I
that's
must, yeah, Dr. Ramide, I must appreciate the aspect of bringing in the professional body to serve as the middleman, because in Nigeria is always I think not just Nigeria, almost third world nation. Even when we see that World Bank, IMF gives loan and aids, the possibility that it will get to the ordinary people is sometimes very it sometimes doesn't happen. So eventually the money floats around the
exact.
elites. Yeah, the aids, the income floats around the elites, and then it's the raindrop effect doesn't exist. But I think that when you bring in people like doctors, professionals to serve as the middleman, the
Exactly.
likelihood that even if it's just going to be a few people more that will benefit from that outreach, I think
Yes,
we
because
hope.
we know
Yeah,
we
go ahead.
know I said we know the burden, we feel the burden, we know that. So for example, when I was in the private government hospital setting, we've had a couple of situations where the consultants, the resident doctors, I mean, you see a patient dying, gasping, cannot afford to dialyze. We actually contribute. How much can you give? How much can you give? And amongst ourselves, doctors, nurses, technicians, we actually pay for a patient's dialysis
Yeah,
amongst ourselves. I mean, it's just a humanitarian thing. I can't watch this patient die because he or she cannot afford it. So I'm like, okay, I have this amount, this person has this amount. So by the time we pull together, we're able to donate for that person. And we've even had situations where an affluent person, for example, brought into our own relative for dialysis and then sees this poor person crying that my son is dying. So we've had situations where that person pays for like 3 or 4 sessions for that particular person. You understand? And this is just, you understand. So by the time we even have well-meaning individuals, NGOs, even some banks, companies can take it up like a corporate social responsibility that, okay, on a monthly basis, we want to take care of 1 or 2 patients to be dialyzing, or a quarterly basis, we want to cover for these people. So they can take it up as a CSR or anything, yes.
yeah.
So we feel the burden, and I think we would not misappropriate. I mean, the professional bodies will not misappropriate funds and get it to those who mostly need it.
Yeah, I must say that I absolutely agree with the fact that it's very less likely that professional bodies with credible oversight will possibly not have this transparency in terms of ensuring that those who are actually in need of that help actually are the ones getting it. Because I remember myself too, like what you said, those are some of the things that we're trained to do as doctors back from uni, where you're trained to show compassion, you're trained to show uh, you're just that humanity in us. I remember then we used to donate blood. I remember working in one of the hospital in Nigeria where it was a pediatric center. Almost on 3 monthly basis, you just need to donate blood because there were some people that couldn't afford to buy blood to keep their own children alive, and they have to depend on medical what's it called, personnel to ensure that they were
Yeah.
supporting. But I must absolutely appreciate bringing that up because as many people that will come across either those watching on our stream what we're streaming live or people that will come and watch recorded session will possibly find that aspect that there are credible bodies on ground that in case they want to support in terms of taking the burden off that there are people that will be willing to help that make that happen. But I think we're gradually coming to the end. Most of my questions here, either you have answered them directly or you have answered them indirectly. So, but if
So,
so yeah. Maybe I know that you mentioned something about when we talk about medication that should be avoided in terms of their ability to damage the kidneys. You mentioned things like diclofenac, ibuprofen. Are there more medications that you think should be avoided when it comes to kidney safety?
yes. So we also have some antibiotics, for example. Some antibiotics are also dangerous, especially prolonged use to those antibiotics. We also have apart from the antibiotics, we also have the herbal. So sometimes people take herbal supplements or herbal remedies for
Mhm.
reasons best known to them. So when
Mhm.
we talk about herbal remedies, people think is the what we call agbo in Yoruba land in Nigeria, where you
Mhm.
take herbs, boil in water, boil with alcohol. So it's not just that. As much as agbo is a Rama remedy, we also have the customized or the produced herbal remedies that can cause kidney products. So we call them, for example, there's something called the herbal nephropathy, Chinese herbal nephropathy. You understand? So most of these herbal complements they have some dangerous chemicals inside. For example, it's called isocolic acid. But those people would not tell you. So when you take these supplements over a long time, over years, it may be damage harmful to the kidneys. Yes, so I remember what I was trying to say. The Chinese herbal nephropathy, it was a cause of kidney disease sometimes in those days. And then this is because of the fact that these herbal supplements contain a constituent called the isocolic acid. So those supplements NSAIDs, like I said, pain relievers, and then some antibiotics can be hazardous to the kidneys. And for people that have a background kidney disease, there are some medications that when you take, you need to reduce the dose. So, for example, if person A that does not have a background kidney disease is taking 10 milligram of that particular medication, person B with a kidney disease may need to reduce his or her own dose to maybe 5 or 6 milligram. So that's what we call renal dosing. So as far as you take the renal dose compatible with the strength of your kidney, there may be no problem. But if you take a dose, the conventional dose that is not the renal dose, it may further damage the kidneys.
Yeah, I also thank you for bringing that aspect up that when it comes to medication, we need to see our doctors to ensure that we're not just prescribing the medication, then we're doing it in such a way that their overall health is taken into consideration. And you're sending a very strong message because in Nigeria, especially in Lagos where you practice, the tradomedical thing is a very, very popular thing that even when you prescribe medication from the hospital, then those mothers or parents will still go to roadside to get the herbal one. And there's this popular Nigeria saying that said, "Onoko waja." I don't know that there is not one single road solves the problem.
Yes,
Maybe we also need to let them know that the kidney sometimes may be crying for help. But I'll say thank you.
exactly.
Yeah, yeah. Please, maybe they need to hear from you that please, when your doctor prescribes these medications, stick to what the doctors are doing. They've been trained
Yes.
10, 20 years in medical training is not something you can just wash away. But I'll say that I thank you for your time. Thank you for making yourself available because I know that at the outset we had some technical issues. But in terms of your take-home message to people that will watch this recorded session, that are watching the live session in terms of caring for your kidneys. Well, what's your message?
So the take-home message is have yourself checked regularly,
Mhm,
check your blood pressure,
mhm.
check your blood sugar. If peradventure any of this is present, if the blood pressure is elevated, your blood sugar is elevated, always treat accordingly and see the respected specialist for regular follow-ups. The second take-home message is do not wait to have symptoms of kidney disease before you suspect kidney disease. Kidney disease may be asymptomatic, that is, may show no signs and symptoms in the early stages until it is advanced. So what do we do? Regular checkup, annual checkup should be an important part of life in everybody. So once you check annually, you know your baseline level so that if you check the following year or if for any reason you visit the clinic for some other things and something is awful, you know that, oh, something has changed from my baseline. Then most importantly, some social practices like smoking, drinking excessively, using bleaching agents should be avoided or should be stopped. And then having a kidney disease is not a death sentence. Visit your nephrologist, follow all advices. If need be to commence dialysis or renal replacement, be optimistic about it. Get the proper hospital and the proper funding if need be. And that if there's a kidney disease that is advanced on the long run, there's the option of dialysis or transplant.
Yeah.
So those are my take-home messages basically.
Man, thank you so much for your time. I think with that, we have come to the end of today's discussion. And to our viewers, we just want to appreciate you for staying in touch. I want to say that you continue to subscribe, tell people about what we're doing. We are here to ensure that credible health information is made available to the ordinary people in simple form. And to Dr. Aramide Akinloye, it's been an absolute pleasure having to host you on our platform to talk about something that you're very passionate about, resolving kidney matters. So once again, we want to say thank you. And we hope that next time when we call you in any subject that has to do with your field of expertise, you will do us a favor of showing up again. But once again, we want to say thank you. Thank you. It's been, I will pray that God bless you for what you're doing for us. We couldn't have asked for a better person to talk
Thank
about kidney disease. And God bless you. Thank you for coming to make your service available to us. Thank you. Um,
Thank you, Dr. Lufeni. Thank you so much for having me around. It was nice gisting with you. I enjoyed the gist. I enjoyed the chat.
yeah,
Can't wait
yeah.
to be back again.
I
Thank you.
must add, I must add that due to some internet concerns, the quality of this video might not be what you expect when you watch it. So I'll send it to you, the recorded version, so that you can watch. But usually, it's still being recorded, or maybe I should just end the recording while we stop recording. Okay, so when we send the video to you, because usually we're going to do post production, we're going to cut off a few parts that are not as the internet was not
All
as
those,
good.
all those things I was saying, You're not recording again.
No, but like, yeah, hopefully, once we are able to, because we are still starting, and once we're able to get ourselves together, we should be able to go past the part of the production that internet might be a significant factor. But I want to appreciate you for coming and for giving us your service. God bless you.
Amen. But was it? But I could hear you for most of the time. Were you losing me at some point?
Yeah, there were quite a few places where it wasn't like I was losing you, but your face will be static and I will hear you
Break.
talking. Yeah,
Oh,
yeah. But
okay.
once once I send the video, you will see what I'm talking about. You see what I'm talking about.
Why now? If it's not good, we should do another one.
Yeah,
Must be good though.
we can
You,
do
now
another
that's why you can.
we can do another one, but I think that will be, but like the time when you did it in the office, that was the quality of internet there was more superior.
Yeah, it's better than the one here.
Yeah, I think it's better than the one here. It's better than the one here. You will
Okay.
see you will see the video. You will see the video. You will see what I'm talking about.
Okay. And let me send it. If not, I can always reschedule to do it elsewhere. If it's
Okay.
not too good.
Yeah, yeah. I will say that in my mind, I think the quality was an issue. Quality was an issue.
Uh,
Mm.
okay. Send it, let me see. If not, we can
No, but
reschedule. But that's the thing. I usually leave the office early as I'm not in the office in the night.
mm,
So if I'm going to reschedule, that means it has to be during the day.
yeah, it has to be during the day. It has to be during the day. Mm. It has to be during the day. But we'll see how we go. I will see how it goes. See how it goes.
And
Mm.
let me see what it looks like. If not, we'll reschedule.
Okay, okay. No, but
It's being recorded. You're recording again.
no, I'm not. I'm
Eh.
recording again. Let me see. No, I'm not recording again. Yeah. Thank you so much. Don't be
All
upset,
right.
but yeah, we
No,
shall
no,
see.
no.
Yeah.
No, it's just this Nigerian connectivity. And I was trying that, and I don't want, I want this thing to be good.
No, but like I said, there are a few part of it that is salvageable. That is
No, no, no.
salvageable.
If it's breaking most of the time, there's no point. Well,
No,
let's see.
I'll share it with you alone first now, and you
Okay,
just
okay.
look
Before you
at it.
upload it.
Yeah,
Okay.
yeah, I'll
All
share
right.
it with you alone. Okay. My greetings to
All
your
right.
kids.
Thank you.
Yeah. Bye bye. God bless you. Thanks.
Yeah, I said it was breaking.
The network.
Mm.
Sorry, I thought you were still talking. I wanted to end.
Okay, no, no, no.
Okay, thanks.
Okay, you can end it.